Okay. Well, welcome everyone, and thank you for joining. I am really privileged to be doing a fireside chat with Elad Walach, who is my host here with me, and Elad is the co-founder and CEO of Aidoc. Aidoc is an innovative radiology AI company. It was founded back in 2016. They now have 7 FDA cleared computer vision triage algorithms and 2 care coordination algorithms, one for stroke and one for PE. They have over 120 employees. A lot, that's probably old data. You probably have more now. And their solutions have been implemented at over 600 medical centers. So we get to talk with someone who's not just creating AI, but who is actually implementing it and implementing it at a significant amount of scale. Elad and Aidoc both have been recognized in the industry. Elad was listed in the Forbes 30 under 30 in the science and healthcare category. And Aidoc has won several awards. Actually, some have come up recently. The most recent one that I saw, and it's not limited to this, was the best AI health application for the UCSF awards. So congratulations. And my name's Nina Kottler. I'm a radiologist. I have been a practicing radiologist for 16 years. I serve as the Associate Chief Medical Officer for Artificial Intelligence at my practice, which is Radiology Partners. And I'm going to be moderating this session today. But again, the session is meant to be casual, and we've got a bunch of people who are on here. And I encourage for any of you, as Elad and I are speaking, feel free to unmute yourself, ask a question, chime in with your experience. If you have questions and you don't feel comfortable doing that, you can also put them in the chat application, and I can mention it as well. I'll start us off just getting a few questions going, but again, if anyone wants to chime in, feel free. All right, so Elad, you're one of the founders, and I know that you have a military background. I think that the other founders as well has had a military background. I was wondering if you could tell us a bit about where you personally came from and how you got into AI and how you chose specifically radiology.
Yes, thanks, Nina. And I really think that first of all, I'm thankful for this opportunity to kind of share a bit behind the hood of I would say, the people behind Aidoc. And absolutely correct, we have over 250 employees these days, so it has been growing pretty rapidly. So a bit about my background. As you know, all people in Israel have the privilege and opportunity to serve in the Ministry of Defense, and as part of that, I personally was had the opportunity to serve as the head of AI for the Israeli Air Force. So no healthcare in my background. I was fortunate to meet my 2 co-founders during that period, and maybe I'll start by saying one thing that I really was passionate about during the service. We work a lot with academia and kind of looking at cutting-edge research. And the one thing that I think really, I would say one of the biggest lessons learned throughout that period was that technology for technology's sake is really cool, but what I personally derive passion from is making things work. And creating technology that is actually operational. The more innovative technology is, the more difficult it is to actually make it work in real life and create impact. And I think this is kind of what's a big part of our approach to date. So yes, we have cutting edge algorithms, and yes, we're innovating in the AI space, but that's not what it's all about. I think what we are about is trying to find ways to use our skills and technology to make a positive impact. And when we finished the service, both me and my co-founders, we all finished the service at the same time. I remember this. We kind of sat together and we said, like, we want to do healthcare. Like to be fair, one of us wanted to do cyber, but 2 out of 3 wanted to do healthcare. So that's good enough. And my personal background. So one of the co-founders had his mom is a primary care physician. So he was obviously a disappointment going to the technology domain. So that's his way to kind of go back to practice. And my dad, Nina, I don't know if you know this, my dad has actually been one of the folks, the original folks working on IBM Watson Health. So I was hearing a lot of the stories at home in the IBM Haifa research labs. So we had kind of hints, but we didn't, when we got it into the space, we just really, we wanted to do healthcare. And I think there are two reasons. I probably don't need to sell the audience on this, but one reason we really wanted to go into healthcare was we just wanted to see that direct impact, right? I think all industries and all startups that create value are amazing. But there is, I would say, a personal preference that, I wanted to see that, like, the text message from a physician that we saved a patient's life, or at least made a good impact on the patient's care. And the fact there are millions of people that we've helped and may not even know about this, I think is really, we find a lot of passion from it. And the other reason why I really wanted to go into healthcare is because of the depth of the challenges. I felt that especially when we kind of learned about imaging AI, it was so, the pain point on one hand was so obvious, but so many companies tried, to be honest, and haven't succeeded in really creating significant traction. We were intrigued. We were excited about kind of, taking on a big challenge and seeing if we can do something different. So those two reasons kind of drove us into healthcare originally, and then obviously radiology as the main focus point.
Yeah, and you can certainly have an impact on, and when you get involved in healthcare, it's just such a personal thing and so important that it's really a great area to get involved in. And I do see that actually you showed me one just at the beginning of this, that your team gets really excited when you get this great feedback from either physicians or patients or anyone that is just saying, you made a difference in my diagnosis, or you made a difference for this patient.
I think this is what drives a lot of the team. And I'll share one story. So our head of deployments, I hope he's okay with me sharing this, but his name is also Elad, and we had like a crazy period of deployments recently, and he was working every day until like 2 a.m., 3 a.m. in the morning, like crazy hours, right? And he told me that after like a tough week, the one thing that's kind of, well, there are probably more things, but the thing that gives him a lot of motivation is the fact that he's like, we have this WhatsApp group of like sharing all these like text messages we get. So it really fuels him and drives him and kind of makes him think that it's all worth it. So if you're a user and you're hearing this and you have a cool case to share, just know like it's what gets us all riled up, what gets us all excited in the morning.
It's nice to actually see the outcome. You don't want to be disattached from that, and making sure that the people who are creating the algorithms, who may be a little bit separated from the effect that they're having, get to see that.
Yeah.
So I don't know if anyone was in the session before this, but I gave a talk about David and Goliath, right? And David being a vendor and Goliath being the algorithm. And I was really saying a point which was something that I learned very early on when we started working with AI vendors, that we're pretty immature in the technology, and it is so important not to just find an algorithm. It's really important to find a partner. And I know that that's important to you, Elad, as well. I was wondering if you could share a little bit about what your story is and how you guys at Aidoc think about that.
Yeah, absolutely. It's really is so important to have the clinical collaboration with the vendor. And I don't want to over abuse the word partner, but I do see this as something that is deeply involved. And what does it mean for us? It means we're actually investing a lot of resources in creating this collaboration. So we have a customer success. Our first hire, I would say, our first hire in the United States has been a customer success person, because we knew we have to engage our customers in a very deep way. And those people are not salesy in any way. Like they're typically PhDs or like masters in biology, informatics, like people that are really scientific, deep and kind of can get deep in the clinical way, can help with analytics. And I think it's really crucial to have this. So that's one aspect. We invest in opening a channel of communication I think that that is really important. The second thing that we do is we, as much as possible, right, is we allow access to the R&D team. So like it is somewhat easy because a lot of our even business folks are kind of technical in origin, like myself, but we do believe it's so important to kind of make customization and adaptation. And the reason why it's so crucial, I think there are two big reasons. AI is still fairly new, and the clinical workflow is not yet figured out. And when I say that, people talk about workflow integration, and when they say that, it typically mean like the IT integration, like how do you integrate into RIS and PACS. But to be honest, that's not the most interesting question in my mind. It's much more about the clinical workflow integration and how do you build a new workflow around this. And to give just one example of what do I mean, one of our products is one that detects incidental pulmonary embolism, right? So nobody's expecting, you're doing, let's say, oncology follow-up, and there's potentially pulmonary embolism that you want to flag to treat that patient with an ED-based turnaround time. And so that's, I would say, the product in of itself. But if you think thoughtfully, you may want to build a workflow around it. For example, some sites of ours wanted to make sure that they always read cases that were flagged by this algorithm while the patient is in the facility, especially important for outpatients because they wanted to catch the patient before they left the facility. So that, I think, is just one small example. There are a lot more of what is, I think, clinical innovation. And clinical innovation we can help, we can share best practices, but the people that need to drive this change, the clinical change of how AI really integrates deeply, those are the clinicians. And that's the only way to make significant transformation into how patients get care.
And I agree. I mean, it's one of the things that we look for in partners is someone that is willing to talk to us about those things. I mean, I don't know, I've been around in radiology many years. So when I first started, PACS just came out. It was 2001. And at that time, the PACS companies were really interested in working with us as radiologists. And the robust sort of improvement in PACS came from that time of that direct collaboration between the clinicians and the technology experts. And that hasn't happened now, at least in my experience, for years. And it's kind of depressing. So be able to go back to a time now where AI vendors are really interested in working with us, or at least the right AI vendors are. So when you're looking for a partner, find one that wants to hear your input, because a lot of the use cases that came out initially when AI first started were use cases that were just based on what did a technology company think that we were doing, right? Everyone thought, oh, you just detect things, so let's just detect things. And I'm going to create a pulmonary nodule algorithm because I have access to those cases because there's cases out there on the internet. But really, you want to do it the other way around. The clinicians definitely know the use case, and if you can't collaborate with the vendor on what you want to do and how you're going to integrate, then they're not really going to be a great partner right now, at least until the technology is a lot more mature.
Yeah.
So I know too, I mean, you guys have now transitioned. You've changed quite a bit. You've created a lot of algorithms, and now you're starting to partner with some other groups and create a platform. So that healthcare networks that want to sort of expand the algorithms that they could use, they could just connect with one group and not have to worry about their infrastructure of connecting with a bunch of different vendors. And that's a transition for you guys. I'm wondering if you could talk a little bit about how you evolved into this solution and where do you see it going from here?
Yeah, I think that's a really interesting question, and about how the market evolves generally. And one of the things that so the first thing we had to develop for our own use is a platform that is fairly scalable, because the amount of algorithms we created, so 9 solutions over the past 2.5 years, we had to find a way to scale pretty easily, because we want to enable more modules at the flip of a switch. And one of the things that started happening as we kind of grew more and more is that health systems started expecting us to help them build an AI strategy and architecture that could make sense for the long run, right? They saw our pace and also like what's happening in the market. And I said, can we somehow consolidate on a unified platform? The challenge, however, is if you really want to do this right, the amount of technical effort that is required is immense to really integrate algorithms well. I initially wanted to do, whatever, like 20 companies integrate them, right? And then my CTO, I remember this, Michael told me kind of like, Elad, you're crazy, and it wouldn't work. And what he said is that like we've actually evaluated is, but to do like a really robust integration takes about 35% of the amount of work it takes to develop a whole new algorithm, right? So it's not for free. It's not like a plug and play. Like these things, especially without API, it's just very complicated. The orchestration, the integration, vetting that it works, like doing the whole that. You really want to build a robust integration that's difficult. So we've decided to invest that. And I'm sure there are a lot of amazing AI companies. I'm not saying we've picked all the good ones, but we've picked a few that we had the same philosophy, the same values about the market, and they've had really solutions that we see often in the market. I'm sure there are more. I'm not saying that we're comprehensive by any way, shape, or form, but we did choose some that I would say stick to the same value, pretty mature, robust, we can trust, we can rely, and we found a good partner that is with us in the philosophy.
That's great. And so it expands the algorithms that you all can offer. So
Exactly.
yeah, I also want to talk a little bit about kind of where we are beyond the radiology hype. I think hopefully everyone here feels comfortable that AI isn't going to replace us. And what Kurt Langlot said is that, right, rads who use AI will replace those who don't, or practices who use AI will replace those who don't. And so you want to get comfortable really quickly with artificial intelligence. I think one of the things that I've noticed is unique about some of the things that you guys offer is that you're doing it to put the radiologist at the center of care.
Yeah.
So there are some there are some care coordination, let's say, platforms that just say, hey, I'm going to bypass the rad, send the information downstream to the other people that can take care of it, and the rad can see what's happening, but it doesn't need to go through them. I think you guys have a pretty unique thought about how you want to keep the rad in the center of care, which is something that I, as a rad, am biased and very passionate about. And I was wondering if you could talk a little bit about how you feel about that in your care coordination products.
Yeah, I think it's a very important point, and you're biased, I'm biased as well, right? That radiology is our home base. We've grew in radiology, and that's our focus point, right? So we want to see the practice and the industry succeed, and I think that we see, I see care coordination as both a massive opportunity, as well as there are some risks, but I think you probably, the folks here at ACR, are even more aware of those. But in terms of the opportunity, I think that radiology can and should be the bearers of AI for the institution. They're very savvy in terms of understanding data and informatics and what to check and what to test for and how do these tools integrate. And I think that because of that, they can be the champions for AI and kind of build the use case, the business case, and how this all works and how to validate this. And I think that if radiologists do that, the workflow that they'll get is also, going to be very radiology focused, right? So for us, because we're so radiology centric, the radiology workflow is very tailored to them, right? You don't want to, go outside the workstation. You want to have like this everything very well integrated and convenient. And I think on the flip side, right, I think that there are other specialties that could bring AI. There are data departments that are coming up. There are other specialties that are interested in consumer medical images. And, there is a question of, if they bring the AI, right, what would be the workflow for radiology? How would this be led? But I mostly look at this as an amazing opportunity because I've just spoke with Nina. This, like, AI has C-suite interested immediately, right? Because it touches all of their service lines. It's immensely impactful. So they all wanna touch this. So I think in care coordination or in general with AI, I think that radiologists, we wanna empower radiologists, give them all the tools and data to show them how whatever they do within their department has massive impact downstream on the whole hospital operations. And maybe just the last point on that, I think that one of the most interesting things we need to do in the AI space is more outcome research. I think that's necessary to fully realize the potential of AI, because the question is not how accurately you can, flag brain bleeds. It's what is the impact on patient care. And what I find really cool about AI research is that it's very hard typically to fully realize what's the impact of better radiology quality, right? So let's say you're starting to read with a specialty, or you're having attending reading at night, or you're engaging with a group that can give you some specialty coverage. Why are you doing this, right? And it's sometimes hard to gauge what is the downstream impact of all of these moves, because it's typically a gradient of change. We're investing in peer review and peer learning and improving quality. And what is the impact of that on patient care? And I think with AI, what's cool is that we're getting this delta in time. So immediately we can get like an uptick in quality or reduction in turnaround time. We can actually measure what's the impact of that on things like length of stay or admissions, kind of like a new procedure. And the research about AI is, in my mind, not even research about AI. It's research about what is the impact of radiology quality. Hey, good news, we can get there with AI, but that's not, it's just a tool to reach that better radiology quality. Then what's the downstream effect of that? Hopefully that makes sense.
Yeah, it's kind of interesting. I've always thought this was a little bit odd. I mean, maybe it's just where we are because all of our data is hard to access. And when the data is hard to access because it's all in different locations, you can't really study it and provide best practices. So a lot of our best practices are consensus among radiology experts. Like, what do you guys think is the best way to do it? And I do think this is going to be an area that is going to be aided by AI, maybe as an indirect way. Because in order to implement AI, you need all of your data to be going to one area. And if you can consolidate that data, and if AI can help us normalize it and understand it better, then it's all in one location. And when it's all in one location, that's when you can start really studying it and gleaning the insights from it. And then the things that we can do can be really data-driven more than consensus-driven, which I think is going to be one of the exciting areas. You mentioned too, and I just want to say this because you told me this, I think maybe a couple of months ago, and you mentioned here that it's really important to have radiologists as AI champions, and that AI can really expand our role in radiology. But there are other groups, other specialties that are looking at AI and saying, well, hey, if AI is telling me the answer and it's 99% or 95% accurate, then maybe I could read that cardiac exam with the AI as a cardiologist, and I don't need the radiologist anymore. Have you seen any of that discussion happening?
Yes, unfortunately, we do see that from time to time, and obviously, there are a few things we can do to mitigate that. Right, one of it is taking I would say stance as a vendor, right, that making sure we keep radiologists involved and in the loop. The second thing that I think is really important in all of this is just make sure, I think it all ties to who's going to be the champion of that. The business industry, right, flows to where it's easiest to go through, right? So if RADs would be the bearers of technology, they would be the champions that would bring it. This would make them, I would say, the practice that navigates how AI is going to shape up, and it can shape up in a way that really benefits patient care to the maximum, as well as the practice of radiology. And I think it makes a lot of sense in my mind that they have the best understanding of how to engage with these tools, not taking decisions that potentially are more risky to patients, right? So I think that this is why, again, we coming back to this collaboration point, this is why I think it's really crucial, especially at this point in time, to have this deep collaboration, because this gives radiologists the opportunity to really shape up how AI is gonna be in the future in a way that really both maximizes care, but also make sure that radiologists take a bigger and bigger role in understanding the clinical integration.
I completely 100% agree. And this is why I think it's wonderful that we have all of these people here at our Informatics Summit today and tomorrow, because it means you're actively learning and you're interested in this. And that's what it requires. This information, we don't get to become the experts in AI by osmosis. We get to become the experts in AI in working with vendors and learning about it, going to conferences, talking to different people, watching people on social media. And when you become the experts, people start coming to you to answer their questions. And that's what we need. I mean, as radiology evolves, we as radiologists, we're used to evolving. This is another evolution. Our jobs are going to fundamentally change, and we need to be the director of that rather than the recipient. Because the recipient, being in the backseat is not a very good place if you're trying to drive somewhere. And I would suggest that as radiologists, we're probably the best positioned to be the leaders of AI. Number one, because we understand technology and workflow so well. And number two, because we are at the center of care. While a cardiologist might see a patient for one thing and then they get transferred to the surgical service, we're seeing that patient as the inpatient through their entire period of care. So thank you all for being here and being part of this. Okay, I'm off my soapbox, but I do want to to transition, because if AI is going to become standard of care and we're actually going to be able to use it, besides Rad's becoming the expert and making sure that that people understand it, it needs to have a business case. And
Yes.
that's been the hardest part so far. Like, we have no money in healthcare. Like, who's going to pay for this? And how do you create that business case until you have a business case? Like, it's never going to get out there. So what have you guys done to speak about, to figure out what that business case might be?
Yeah, I think it's a very important question for the ecosystem to learn about. And there are three, maybe four parties that can pay for this. There's the payer, the health system, the practice, or the patient, right? Let's put patients aside. I think it's less, I would say, probably less relevant. With the payers, I must say that there is big difficulty, A, because those are very long cycles, but B, because I think what we saw is that payers are reluctant to pay for, let's say, augmentation, right? They are kind of, well, Rads, you should just read better, right? Which could be a viable approach, but I think a lot of the augmentation tools that are out there are difficult to convince payers to kind of really see the value and pay a premium. So that leaves us, I would say, with the provider and the practice. And I think both have very different business cases, right? What the health system, what they care about typically is the broader health system operations. I think that because radiology is so pivotal to all of healthcare and all health system operations, 70% of inpatients, 50% of AD, and generally most advanced treatments, I think there is massive downstream impact. We just need to measure that and be thoughtful about the translation of that. And this is why I'm excited about the kind of oncoming wave of outcome research. I think it really shows the ROI. If you can show reduction in ED length of stay, if you can show reduction in inpatient length of stay, potentially more procedures because you're reaching the right patients on time, relevant transfer patients, all of those things, if you can show how it impact those, or that's what we've been able to see and we found resonates well, then the health systems are more than willing to pay for it because they see they're investing in a core capability, and they're getting a much bigger benefit in return. This is why, for example, this is an example of the payer, but a payer, willing to pay $1,000 per stroke AI patients for CM, like for Medicare. True, it's through kind of a temporary program called the New Technology Add-on Payment, but still, it's $1,000 per AI analysis, which I think is, if you're comparing that to whatever $100 you're getting for a read, 50 to 100, then obviously because the tie-in is for a much bigger picture of patient care, all of that could make sense potentially. So hopefully, I'll pause here before getting to the practice, but hopefully that makes sense in terms of the big picture for, I think, the business case for health system is how better radiology quality driven by AI which is turnaround and diagnosis and efficiency, how does this, at the end of the day, translates into better hospital operations, more revenues, and lower costs?
Yes, more revenues and lowers costs. Values in the eye of the beholder, and what do the beholders care about? So the beholder for in the healthcare system, the hospital, they do care about quality, of course, but that's a baseline. That's expected. And so, are you going to get people to pay for quality? I thought no for sure was the answer, and that it was only about ROI. But I listened to a webinar that you had with someone on your blog, and it was someone that had been in the on the healthcare industry side, on the provider side, and he said that there are some cases like every year the hospital will determine an area of quality that they want to improve upon, and so maybe that's stroke imaging, and so you could potentially get people to pay for that if that's part of their quality assessment for that year. But in general, it's more about the hard dollars, and how do we save money, or how do we earn money for that group.
Although I must say, I found something here that was counterintuitive, but unexpected to me. So we oftentimes speak with C-suite in order to kind of get the AI adoption, especially the budget. And I was surprised, somewhat surprised, because you hear this all the time. They only care about dollars, right? They only care about dollars. But when I speak with C-suite, oftentimes what really sells or gets them, excited and passionate about something is the quality, is patient care. And the ROI is something that also needs to happen, right? It's not that they don't care about this, but the conversation should be driven, oftentimes, depends on the person and the institution, but oftentimes it's driven by patient care. So I was very pleasantly surprised. I know all of us here are here for patient care, right? And I know administrators are there as well, but you hear that oftentimes it's a very, people wouldn't pay for quality, but I do think that quality and patient, quality and safety are big considerations for many health systems. At least those that I spoke with.
Well, that's always good to hear, because ultimately, I think that's why probably all the people on this call went into healthcare, was because ultimately we're thinking about the patient and how we can drive better quality value outcomes.
Exactly.
So you did mention too that there's a value for the radiology practice. What would that be?
Well, for practice, it's a different game, because practice is typically, so there are three angles I think that practices think about, right? So the first is efficiency, right? If you can drive better efficiency, obviously that either lower costs or increases revenues, however you want to look at it, but that's very meaningful. The second thing, however, is SLAs, right? Especially triage AI. It's becoming more and more complicated to hold the turnaround time as the number of the caseload grows and the expectations remain the same. So having tools that really can help drive down turnaround time and get to the right SLAs for the right patients, I think that's also a big consideration. And then the third, which is quality and innovation. I think that's also very meaningful, especially as more and more practices adopt AI. I think that making sure that you can provide your providers or patients at the same level of quality that they can receive elsewhere, I think that's also a consideration. So we do see a lot of practices leading the front and adopting AI, either for efficiency purposes alone or because of the other reasons as well. But that's my perspective, Nina. You might know much better than I.
Well, I will say that it's such a hard time in radiology right now, with there's way too much work for the amount of radiologists that are out there, that anything that we could do to improve some efficiency and decrease burnout is a wonderful thing. And I'll also say that using AI and being technology forward is a great recruitment tool. So people want to join practices where they're using modern technology and trying new things. It's what makes radiology, part of what makes radiology exciting.
Yeah.
There are some questions and points that are coming up now. I want to make sure we get a little chance to read through some of them. And feel free, if you guys want to chime in, you can unmute yourself and just say something. In the meantime, I will read some of the comments. So Howard, thank you for mentioning this. The agreement that data science education is really important, and that the ACR is working very hard on that, along with the ABR and the APDR, which I don't actually know that one. Maybe you'll have to tell me what that one is, about how to raise data science training as a priority. That is essential, because even if we learn, this is continuous learning. We need to make sure that we educate the trainees so that when they come into the our specialty, that they understand how to manage this kind of technology.
Hi, Nita. That's the Association of Program Directors in Radiology. They're actually the doers and shakers that actually shape the programs and the educational curriculum. So they've been real active and they've been great partners in developing some concepts of working together. But I've been on a soapbox lately talking about data science education. So any help this group could do, and if we all talk it up, I think we've created at least some momentum. I know the DSI has some modules out there that we're trying to roll out. Even international partners are trying to get, but really trying to ingrain data science in radiology education. Thanks a lot.
Wonderful. Yes, thank you, Howard. I also would suggest that we need people who are great translators between the art of clinical radiology and the technology of data science. And I bet a lot of you who are listening can function as those translators. So you don't need to understand the statistics of everything that's going on, but you just need to be able to translate between what are we missing, what are our use cases, and speak with the vendors about that. So Juan mentioned some need for legislation, no payment or RVU counting for self-referral of AI use. So neurologists cannot get paid or get RVU bonused on AI algorithm use on their patients. I don't know, Juan, if you want to say a little bit more about that.
Yeah, I just feel like I totally share your concerns. I feel like we are creating a shadow system, and you would never go into a 747 and say, we don't need the trained pilot anymore because autopilot takes you most of the way. But that's kind of the attitude, unfortunately, among most people who are not in radiology and healthcare. And so, we need some boundaries. We haven't created these boundaries in the past, and you have in-office exemptions and so forth, leading to inappropriate utilization, overutilization, and substandard care in many cases. Similarly with POCUS, we're seeing ultrasound being used by physicians, and they're doing it because they can get paid for it, and maybe not because it's good for the patient or because it improves care. And so I think I can see AI in this. They're not going to recognize when AI is not telling you the right answer, like a radiologist might. They're not going to double check. They're just going to blindly accept. I work in cardiac, and we do CTAs and look at every piece of the data, and you'd be amazed how many cardiologists are reading CTA based purely on the NPRs. So the curved NPRs that the tech creates, that's all they're using to diagnose heart disease. And they're not even looking at the original data set or considering anything else about the study, and they're getting paid just like we are. So I frankly, it's great for people to say, hey, we're gonna abide by this and keep the radiology central and so forth. But I think there need to be some legislative boundaries created, or the field will deteriorate, and you won't have radiologist involvement, and then the field won't progress because you won't have the people who are best suited to improving these things present anymore.
Mm. It's a great point, and I'm glad we have the ACR on our side helping with that from a legislation standpoint, and also really important that we have vendors. I mean, Elad, you mentioned this, that you're trying to put the radiologist at the center of care because that's where you believe the value is. And so it's important to make sure that we're working closely with our vendors on that. I think, Howard, do you have a point to make? I see a raised hand. Okay.
Thanks.
Oh, yeah.
Sorry.
Yeah.
I had mixed feelings about saying something. I agree with Juan. We need to be proactive about putting boundaries around that. I just, for one, the group and Biv and others can chime in here. We fought the battle of self-referral a long time ago, and that did not go well, didn't gain much traction there. I would urge that we continue to stay ahead of the game, that we put ourselves out and we establish radiology as purveyors and keep moving the target forward. So we lead from in front. Innovation has always been the way that radiology has been successful, and being expert in data science and really knowing what we're talking about. providing that expertise to our administrators and other stakeholders, I think will really serve the profession going forward.
Great. Thanks, Howard. Laura has this great question that I want to make sure I get to, and Elad, I'd love to hear your response to it. So she says, if healthcare systems are the ones paying for AI, how will that affect the disparity of healthcare access and care when not all the healthcare systems may be able to afford or prioritize purchasing AI?
Yeah, I think that's a really good question. And as always, it could be a double-edged sword. I would say, however, that I see this more as an opportunity to create more consistent quality across health systems or between health systems, because at the end of the day, to really justify buying AI at the main market, it has to have positive ROI, which means that it makes sense for any health system. And I would argue, especially for those that are more community-based and have potentially lower quality care, yes, you may be investing money in adopting AI, but you are also getting a return because you have, lower length of stay or lower time in the ED or whatever it is the AI you're adopting, right? I think that's the only way that AIs can be widely adopted in the main market. And I think if that is the case and it makes sense for everybody, but especially if everybody, those that potentially have lower quality operations, I think then it can be actually a force for equalizing and creating more consistent quality. And I think that's the opportunity. Of course, if it is a challenge, right? If AI wouldn't be perceived that way and would only be bought by the academic, which is not what we're seeing, by the way, which is good, then obviously it can create greater gaps. But I think we do have an opportunity here as long as we keep focused on things that really create value and are not, things that just enhance quality, but actually enhance quality, but can also drive the financial and operational outcomes that we're searching for.
Yeah, I agree with that. I do see AI as a great equalizer. And a lot of what it's shown is that it elevates the standard of care to that of a subspecialist. And we don't have a huge number of subspecialists, so we can elevate the quality of care for everyone. But the other part that you said is really true. So there is an ROI that hospitals aren't going to buy it unless there is an ROI for them. And so if there is positive impact, so money that is coming in, then those groups, even the ones that are not making a lot of money or have really razor thin revenues, they can afford to do this if you can prove that there is an ROI beyond just the quality added. So I think that's really important. Has that been something that hospitals have been responding to? Are they needing to do a pilot in order to prove the ROI, or are they okay listening to what you've seen from the data that you've proven with other groups? Is that enough for them to move forward?
Yeah, I think that's a great question, and it ties into the point that Howard mentioned earlier about data science education. I think that apart from the data science part, I think that the translational piece of how AI really impacts downstream operations, I think that's also a critical piece. Yeah, that we would appreciate if more people would be informed on how to sell this internally, how to build the businesses, how to think through that. But going back to your question, Nina, I think that typically they believe the assumptions as long as it's validated and we can show them the clinical data or other sites. They do typically want to test that at least roughly it matches their own environment. So they wouldn't, typically a community system wouldn't necessarily buy in something that we validate in academic and vice versa, right? So they do believe as long as you have a similar enough institution that drove this. But fortunately, by now we have enough data points for this to matter. And I think we need to keep working together with our clinical partners on outcome studies. I think that's a necessity.
Great. Well, I know we only have 1 minute left, and I just wanted to give you 1 minute to see if you had any summary statements or anything that you wanted to say to the audience, and then I'll close out with just a note of where we're going next.
I will. First of all, I'm very thankful for this session, the opportunity to speak in this summit. I think that there are a lot of changes in the radiology ecosystem right now with AI. We're proud to be partners with a lot of you to drive how AI would work. And I would say, keep being very open to the clinical collaboration. We can't do this alone. It's not right, but we also can't. So it has to be a work jointly of radiology and technology in order to make the transformation what it could be.
Wonderful. Which means there's a call to action to us too as radiologists. Get involved and find a partner. Don't find an algorithm. All right, there is going to be a 15-minute break from 2 to 2:15 Eastern time. After that time, please rejoin the live stream for the 2:15 presentation that I think is Chris Roth debating the future of PAMA and clinical decision support. So that should be a really exciting, very live session. So thank you everyone for coming, and we will see you on the live session next. Thank you.